This video is for awareness purpose only and not a substitute of professional advice or treatment. Acute Ischemic Stroke Approach and Management. Dr. Amit Kumar Sinha, MD DM Neuro, Senior Consultant, Neurologist. Pathophysiology of AIS. Death of neurons occur due to compromised blood supply. The normal blood supply of brain tissue is around 60 ml per 100 grams, that is 20% of the cardiac output. At the supply of 30 ml per 100 grams, the neurons and the brain tissue becomes isoelectric, and that is salvageable damage. At 20 ml per 100 grams, bioenergetic failure occurs and the cell becomes non-salvageable. At this time, sodium and calcium enters the neurons, leading to cell swelling and death of the cells, that is neurons. In MRI, it is shown as umbra and penumbra. Umbra is non-salvageable part as shown as DWI positive. Penumbra is salvageable part shown as PWI positive. Acute infarct. MRI in acute infarct is DWI positive and flare negative. Prompt recognition of stroke. Few mnemonics are used for prompt recognition of stroke by patient, caregivers or paramedic. First is FAST. F stands for facial environment, A for arm, S for speech, T for time. B fast. Here balance and vision is included apart from fast. G fast. Gaze is added apart from fast. Fasted. Eye deviation and denial is added apart from fast. If any of the above findings are seen, immediately rush to a stroke ready hospital. Exact time of onset is very important. Exact time is very important for treatment plan. If exact time of onset is noted, the window period for IVT is 4.5 hours. Whoops, that is feature of stroke on awakening. In this patient, last known normal time is noted. If patient comes within window period, eligibility of IV thrombolysis is checked.
Urgent evaluation.
Urgent evaluation is done to rule out hypoglycemia, TIA or seizure. Patient within window period. If the patient has come within window period, that is 4.5 hours, then activate the stroke team, which comprises of neurologist, lab, radiology, pharmacy, neurocritical care, blood bank, interventionist and neurosurgeon. The door to needle time goal is 45 minutes. Fast evaluation of NIHSS by ER physician should be done. Side by side blood profile is sent. The imaging should be done with CT scan of head plane to rule out ICH. And other exclusion criteria. Patients eligible for IV thrombolysis falls within window period, that is 4.5 hours, no bleed or dense MCA sign in CT, the MRI DWI positive, and the aspect score is 7 or less than 7. To save time, plain CT is preferable. Sooner the better. IV thrombolysis is given ASAP to have better results and less complications. Contraindications of IV thrombolysis are hypoglycemia less than 40 mg per deciliter, ICH, dense MCA sign, neoplasm, ABM, aneurysm, dissection, active bleed, recent history of head injury or stroke, bleeding diathesis, infective endocarditis or NIHS more than 25. Endovascular thrombectomy or EVT. After IV thrombolysis in eligible patient, if large vessel occlusion is suspected, MR angiography, CT angiography or DSS is done for possibility of EVT. If exact time is not sure, like in whoops, and the last known normal is within 24 hours, then MR angiography, CT angiography or DSA is done for possibility of EVT. For IV thrombolysis, two TPA are used, RTPA and TNK TPA. RTPA is given at the dose of 0.9 mg per kg body weight, 10% bolus and rest in NS over 1 hour. TNK TP is given as bolus only. The dose is 0.2 mg per kg body weight in India. The monitoring is done for GCS, NIH, SS, BP, sign and symptom of bleed or sign of angioneurotic edema. Suspicion of bleed as indicated by deteriorating GCS, pupillary asymmetry, falling BP, tachycardia, bradycardia, artery bleed, catheter bleed, gum bleed, or falling saturation. If yes, stop infusion of RTPA, send CBC, fibrinogen, blood grouping and cross matching. Give cryo 8 units if fibrinogen level is less than 100. If excessive external bleed is there, give aminocaproic acid 10 gram into 100 ml NS over 1 hour. Get urgent CT scan, head done, and if ICS is there, get a neurosurgeon urgent referral. Orolingual angioedema. If yes, maintain airway, discontinue RTPA, give injection methylprednisolone 125 mg IV followed by injection diphenhydramine 50 mg IV or if required, injection epinephrine 0.5 ml subcutaneous. After uneventful IV thrombolysis, if features are suggestive of LBO, then EVT should be planned ASAP. Angio suggestive of IC or M1 occlusion, timing between 6 to 24 hours, age 18 or above, NIHSS 6 or over 6, aspect 6 or above 6. It is advocated on the basis of two trials, diffuse 3 trial, which is based on diffusion, perfusion mismatch which suggested EVT within 6 to 16 hours, and the Dawn study, which is clinical imaging mismatch which suggested 6 to 24 hours. Post IV thrombolysis if uneventful after 24 hours. Repeat CT scan head. If no bleed, start aspirin 325 mg OD or DAPT if indicated. Comorbidities to be considered and managed accordingly: hypertension, diabetes, dyslipidemia, cardiac ailment, thyroid, coagulopathy, etc. For raised ICP, osmotic agents or hyperventilation is useful. Other treatment as per the indications is done. Treatment of CVA and comorbidities to continue as per doctor's advice, along with rehabilitation, physiotherapy and occupational therapy, DBT prophylaxis, dysphagia screening, depression screening, care of bladder, bowel, back and nutrition. Thank you.